Good afternoon, colleagues, and welcome to this session of the Global Community of Practice on Key Populations Programming. We actually have our fourth session. There was already a session this morning, and now we're having a second session today on the same topic, on scaling up effective programs with young key populations. And if we look at the state of the global HIV response on how the epidemic and the response is evolving, there's a very interesting observation that we can make on young key populations. If we look at young people in general and look at HIV incidence, we see it's high, particularly in some specific locations, mostly in Eastern and Southern Africa. This is where we see high HIV incidence among young women and among young men in the overall population. So programs that we have for young people with high HIV incidence in the overall population can be quite geographically focused. If we looked at a map of high HIV incidence among young women who sell sex, we actually would see that this map would cover much of the whole of Africa, not just specific locations. And if we look at other young key populations, young gay men, if we look at young transgender people, if we look at people who inject drugs, we actually see that this is a global challenge that we have in terms of scaling up programs to reach young key populations who are affected globally by the HIV epidemic. And at the same time, we see in our responses, although this is a global challenge for the epidemic, we see major gaps and large gaps in coverage, but also a lot of policy and structural barriers to programming. And all of this is in the focus of these sessions, and we'll have an overview presentation at the beginning, and then a lot of practical examples, including an interesting movie. So we'll actually go to the cinema as part of this session and see an impression there as well. So a lot of interesting work to be presented from government and community voices, bringing those different perspectives together. And we're looking forward to your questions and comments in the chat as well. And I'll hand over to Carrie maybe for some housekeeping announcement and on how the session will be run.
Thank you, Clemens. Hi, colleagues. So this webinar will be taking place in English as the primary language. But if you go to the bottom of your screens, you will be able to select a different language if you have a preference, French or Portuguese or Russian or Spanish. I'd like to ask colleagues to please introduce themselves using the comment box feature of Zoom. If you have any questions, please put those in the question and answer box, because our panelists and presenters will be answering that live throughout the webinar. And just to say that this slide deck and the recording, as well as any linked videos or documents, will also be made available and emailed to everybody on this call. So we'll certainly be sharing that as soon as possible. So thanks so much, Clemens. I think that's it in terms of housekeeping.
Thanks, and I'll hand over straight to Boyan Konstantinov for an overview on the global evidence and guidelines, providing really a global policy and programmatic perspective on young key populations. Over to you, Boyan.
Thank you very much, Clemens and Carrie, and hello from New York, everyone. As I said in the chat, my name is Boyan Konstantinov. I do policy work at UNDP, focusing on key populations, LGBTI rights, and inclusive development. I would like to give credit also to my colleague from UNFPA, Dr. Ilya Zhukov, who presented at the earlier session through a pre-recorded message, and I am using some of the slides that Dr. Zhukov and colleagues from UNFPA provided for this presentation. Next slide, please. Yes, so the strategic settings, I don't think we need to go much into this, but I just wanted to flag that the strategic documents that guide our responses now in general in HIV and specifically about key populations, pay special attention to young people most at risk of HIV and young key populations. The political declaration that was adopted in 2021 stresses that while key populations, while young people are 16% of the global population, they account for 28% of the new infections. And it's a paradox that while the HIV epidemic is getting older in the sense of people on treatment living longer, it's also getting younger because ever younger people acquire HIV. And the knowledge among young people, including young key populations around HIV transmission has not changed much since the 1990s, which is a really worrying piece of information, considering that we have so many digital tools that can help us actually increase this knowledge. So here you see the concerns and the strategic commitments in the political declaration, and they resulted, of course, in the adoption of the Global AIDS Strategy. Next slide, please, which also talks perhaps more than any other strategy that the joint program that UNAIDS has had in the past about young key populations. And that's not by chance. When the strategy was being developed, in order for it to be informed, we carried out consultations with communities, and UNDP, where I work, in cooperation, of course, with other co-sponsors, with a lot of communities around the world, young key populations, was responsible for collecting this feedback. I personally was astonished by how different the needs turned out to be compared to what I perhaps somewhat naively was expecting them to be. So listening to communities, to young communities, was essential, I think, and it's great that we have these strategic settings now in the Global AIDS Strategy, but it will also be great if we deliver on the pledges that the political declaration and the strategy have made vis-a-vis young key populations. And you can see here, we're aiming at more community-led programming, peer-led outreach, increased use of digital technology, combining peer-led outreach with collaboration with young innovators and all these 21st century buzzwords, but also we are also looking at quality, gender responsive, age appropriate, comprehensive sexuality education program, and redesigning HIV services to meet the needs of young key populations, what I just talked about. So a lot remains to be done, and this can only be done if there is meaningful participation of young key populations and their communities in the program design, in the program implementation, and in the program evaluation at the later stage. And as you know, or many of you know, the work of the joint program with and for key populations was recently evaluated. The independent evaluation is, I believe, now public on the internet. And there were a lot of messages around the need to make services for young key populations more acceptable, affordable, and responsive to the specific needs of young key populations in our responses. So next slide, please. Some considerations that I would like to put on the table or on your computer screens before we proceed. When we're talking about young people in general and young key populations, as I mentioned, there is increased vulnerability to HIV and to other STIs as well. To some extent, there are opportunities to negotiate safer sex through virtual tools, the dating apps, but there's also increased exposure to earlier sexual contacts, for instance. And as we said, the level of knowledge as to how HIV is prevented has not increased by much. And in many cases where prevention is available and where HIV treatment is available, particularly in the global north, there are worrying signals that young key populations, especially young MSM, are not perceiving HIV as a bigger health threat. This is something that is of real concern. There are concerns around sexual and reproductive health and rights, co-vulnerabilities related to the increased need of psychosocial support, of peer support and counseling, the different health needs that we mentioned in the beginning, as well as the poor access to services, particularly prevention, but not only, and then the uptake and retention of young key populations and adherence to these services. Next slide, please. And that's a major factor, that there are legal and structural barriers that actually prevent us, so to say, from spreading our wings and prevent key populations from accessing services in HIV. Age of consent is a major constraint in many jurisdictions around the world. Young people and key populations need parental consent in order to access testing, in order to access treatment, in order to access prevention. The design of services, as we said, is sometimes led by what is available for adult key populations, and this is not what young key populations need. So very often the package that is available is either not appropriate, not adequate to the needs, or it is provided in such a way that it is physically not accessible. It is provided by people who do not necessarily have the experience to work with young key populations, and it is not acceptable as a result. And then there is the stigma and discrimination factor, which is really problematic in general when it comes to people living with HIV and key populations, but particularly problematic when it comes to young key populations. And a lot of the stigma and discrimination, as well as violence, is actually happening in virtual space. And we are still, I should say, not best prepared to address these new forms of stigma, discrimination, and violence. We're learning as we're doing, but we need to do more, and we need to be smarter in order to be able to address these new forms that prevent people from accessing services and actually increase the spread of HIV among young key populations. Next slide, please. Now, there is no opportunity. I have actually, the colleagues were very generous with the time, but there is no way for me to put all the guidance documents when it comes to key populations and young key populations on one slide or even in one presentation. So I'd like to direct your attention to a very interesting toolkit that is actually developed with community participation. It's led by UNICEF, UNDP, NFPA partner with the UNICEF colleagues and communities, the so-called Aykv Toolkit, which is a collection of global, regional, and country resources. And it focuses specifically on young key populations and young people living with HIV. It's a great toolkit. It's constantly being updated. Sometimes it's a little hard to catch up with the pace because a lot, especially now, a lot of regional and country resources, some of them excellent, were produced. So I encourage you to look into them. There is, as I said, no opportunity to list everything here. But of course, there are the upcoming consolidated guidelines of the colleagues from the World Health Organization. And they were developed in a very participatory manner. So it's not a paternalistic approach. It's the other way around. So communities were asked, communities were consulted, and they provided input on how to provide services to key populations, including young key populations. This information is mostly concentrated in what is likely to be Chapter 8, and including an excellent diagram for successful programming, which shows the 5 factors that are being considered in successful programming. For instance, quality of services that are friendly, affordable, and confidential, safe, easy to access, comprehensive services that are integrated and decentralized, then the developmentally appropriate information, and then, of course, the people who provide the services, healthcare providers, peers, educators, that are well trained, and of course supportive and make use of peer-based and peer-led initiatives. So these are excellent recommendations that are there and will be rolled out by WHO colleagues in the very near future. There's also a young people and HIV tool that was produced by the UNAIDS Secretariat. Last but not least, often forgotten, unfortunately, excellent implementation tools that were developed with community input, very strong community input actually, and are very comprehensive. And that's perhaps the reason for them sometimes not being that much on the forefront, because some of them are huge in terms of volume. You don't have to read everything, you just need to consult the relevant section. And in these implementation tools, the SWIFT, the MISMIT, the Transit, and the I Do It, you have excellent information about young key populations that is also very well systemized by regions. So it's an excellent opportunity, in my opinion, to find information that is relevant to the needs of key populations, that is community driven and has been approved by global community organizations who work with the joint program. Next slide, please. Now, we don't really have time to focus this so much on these topics. And if we start tackling things in detail, it's going to take forever for us to do this presentation. And the presentation was mostly on data settings and global guidance, but we also have to mention some specific concerns when it comes to the different key population groups. For instance, I mentioned already among young MSM, the significantly higher STI and HIV incidence and prevalence. And while the new virtual tools give opportunity to young MSM to negotiate safer sex, they also lead to increase in sexual contacts. There are new phenomena such as chemsex that have to be addressed. So the key message there is that prevention is of critical importance and has to be perhaps rethought in order to be much more available and much more focusing on young MSM. Then when it comes to young sex workers, I have to point out here that the joint program defines this as 18 plus. So we're talking about adults and we're talking about free will. We're talking about agency. If it is coerced, if it is forced, if it is strict, then this is not sex work, just flagging this. Age of consent, design of services, sexual and reproductive health and rights services, and stigma and discrimination are all major factors that impact responses. When it comes to young trans people, unfortunately, we know that 2021, last year, was the deadliest on record when it comes to extrajudicial killings of trans people, and many of them were young trans people. So violence is a huge factor, as are stigma, as are discrimination. You might have seen the Ipsos survey results, how many more young people globally in the global north and the global south identify themselves as trans. So there's clearly a need also to intensify services that are appropriate for young trans people, focusing on high-risk behavior, focusing on a lack of knowledge regarding HIV infection, definitely addressing violence, stigma, and discrimination, and also definitely dealing with recognition to begin with, and also with what I mentioned earlier, the increased need of psychosocial support and peer support in order to ensure mental health issues. So it's a very comprehensive set of factors that need to be addressed in order for us to be able to provide services to young transgender people. When it comes to young people who use drugs, there is evidence that age of initiation of injecting appears to be decreasing. And there are many other factors that need to be included here, such as accidental injury, self-harm, suicide, unprotected sex, particularly, again, relatively newer, although not really new, phenomenon related to the use of stimulant drugs. And of course, the factors that are related to age of consent and legal barriers that might prevent the access to prevention services among people who use drugs. Now, young people in closed settings, that's also an often left out group when we discuss specific concerns. I decided to put it here in the slide, also because colleagues from UNODC, the Drugs and Crime Agency of the UN, have done a very nice technical brief to which other co-sponsors, including UNDP, contributed, that covers HIV in closed settings and has specific recommendations when it comes to young people. For instance, that young offenders should be held separately, which is not always the case, not nearly close. That children and young people held in detention need access to gender-focused, human rights-based, and comprehensive sexuality education. And there is always the need to follow a human rights-based approach and principle of equivalence of health in prison. Next slide, please. Okay, so we are now zooming out after we zoomed in. And here you can see a set of principles that are very important for programming with young key populations. I think I might be repeating myself, but I'll say them nevertheless. There is the do no harm principle. There is always apply a human rights-based and evidence-informed approach. Be user-friendly. Be gender sensitive and gender transformative and affirming sexuality, and be participatory. Next slide, please. And the enablers. So you can see here 4 columns in which, together with UNFPA colleagues, we grouped these enablers. One is something that UNDP is working on, as many of you know, on laws and policy reform. This is part of our Division of Labor of the UNAIDS, where UNDP is convening the work, moving towards decriminalizing behavior of key populations and young key populations, developing an approach that is going to provide reasonable, working, sensible age of consent model to services, to access services, legal gender recognition and recognition of transgender people, access to justice and legal support, including for young key population, but not only, combating stigma and discrimination. And I'd like to combine column 2 with column 4. Column 4 is on violence prevention and response. As I said, when it comes to young key populations, we have another parallel universe that exists in virtual space when it comes to violence, discrimination, stigma, cyberbullying. So there is also a need to focus in what is happening in the physical world, but pay attention in what is happening in the virtual world as well, because it is as important and sometimes even more important for us to have prevention and response system, and also support to persons who are experiencing violence. There is a need to train and sensitize everyone, including health workers, on the specific needs and the specific approaches to work with and for young key populations. And we need to empower communities to participate meaningfully in the design, implementation, monitoring and evaluation of these programs. Next slide, please. And I saw Clemens switch his camera on, so probably running over time. Very quickly on COVID before I conclude. Yeah, there is barely a presentation without a slide on COVID these days, but it's true that young key populations were gravely impacted by COVID-19. Mainly young, but not only, young MSM and young trans people, and it was related to vilifying, victimizing, forced eviction, over-policing, increasing of homelessness, gender inappropriate restrictions during the lockdowns, and many other factors. There are also a lot of socioeconomic consequences when it comes to young key populations following the COVID-19 crisis. But there's some good practices when it comes to, for instance, peer support in virtual space. This is something that UNDP was also very actively working on, partnering on in Asia and the Pacific, for instance. There were some excellent digital apps and platforms, some excellent new modalities of how services can be accessed. So we definitely should look into also the lessons learned, but the good practices that were established because of the emergency, and make sure that whatever is good is retained and is multiplied. And on that, I conclude and would like to thank you for your attention. Sorry if I took a little bit extra time. Thanks.
Thank you, Boyan. No, that was spot on. And I think you're ready to go from your great overview and introduction actually into a practical approach to implementing programs with young key populations. A national program perspective will be presented by Mary Mugambi from NASCOP in Kenya. And Kenya really has been a leader in key population programming and shown how much change can actually happen within 1 decade. Programs building up and responses for different key populations, including good practices for young key populations, which Mary will introduce now. So over to you, Mary.
Thank you, Clemens. Good evening, good morning, everyone. I will be presenting on behalf of NASCOP, the Ministry of Health in Kenya. My presentation is on programming with young key populations in Kenya. So looking at the context of key populations in Kenya, Kenya has a mixed epidemic, and key populations in Kenya include female sex workers, men who have sex with men, people who inject drugs, transgender people. People in prisons and closed settings are also considered as vulnerable populations, and key populations contribute 33% of all new infections. So Kenya is basically, for key populations, it's a high prevalence. The estimates of key populations are for FSWs around 197 and 096. For MSMs, currently we have about 51,000. For people who inject drugs, around 35,000 and 4,370 transgender people. Sex work and drug use and also same-sex relationships in Kenya are criminalized. So we operate on the basis of health rights and make sure that they get biomedical, structural, and interventions as per our program guidelines, which I'll go through briefly. So the key population numbers are that, and for female sex workers, we have about 29.3%. For those of female sex workers, HIV prevalence. For MSM, the HIV prevalence is around 18.2. And then for PWIDs, about 18.7. Next slide. So our focus on young key populations is that 42% of all new adult infections occur among adolescents and young people, and that is between the ages of 15 to 24. In 2015, in Kenya, we developed the fast track plan, and this was to end the HIV and AIDS among adolescents. Actually, it's to end AIDS among adolescents and young people. And the transition study was conducted in 2015. This study showed us that adolescents and young women engage in casual sex, transactional sex, and sex work in locations where sex workers congregate, but have very limited access to prevention services. So as NASCOP, we conducted an assessment among young key populations in 2017, and that's why we found that their risk and vulnerability was higher than the rest of the key populations. So NASCOP also conducted key population size estimations in 2020, and we found that 10 to 12% of the key populations in Kenya are below the age of 18 years. Next slide. We then proceeded to develop a policy guidance because it's not easy to work without policy guidance. So unless you have policy guidance, then the health workers do not have the confidence to work on this. So based on that evidence and a lot of consultations within our technical working group, we developed the National Implementation Guidelines for STIs, sexually transmitted infections, and HIV programming among young key populations. Remember, we already have another guideline to another one. So proposed, this is the package of intervention, and it's based on global and national guidance, and it's recommended in the adoption of a combination prevention approach. Next slide. This was a pilot project, and we looked at it, the interventions with young men and women who sell sex around Mombasa. And the partners are as that. I won't go through the partners, but basically what you can see on the chart is the numbers kept going up and just finding the young people who are operating and are selling sex within that area. Next slide. What our Scalar plans are, we've consolidated the evidence from research, assessment, and pilot programs, and we have documented the same. We've also the advocacy. We are working on scaling up advocacy for key populations and community networks, government, and all stakeholders. We have the M&E, like data, which is disaggregated by age, because so that we can be able to tell who are the young key populations. And then learning and evidence has been included in the Global Fund proposal for scale up in different geographies and young subpopulations. Shortly, we will be showing you a video on young key populations in Kenya. Thank you, I hope you enjoyed.
Kenya is a country of great diversity. Straddling the equator, it is home to the Big Five and cultivates some of the world's richest coffee and tea strands. With the savanna within its borders and the Indian Ocean off the coast of Mombasa, the Kenyan landscape is a cataclysm of contrasting beauty. Home to 50 million people, it is against this background that one of the largest HIV epidemics in the world exists. According to UNAIDS data, 42% of new HIV infections occur among adolescents and young people. Part of these are young key populations, and they represent the proportion that is at a higher risk of contracting HIV and include young men who have sex with men, young women who sell sex, young people who inject drugs, young transgender people, and young people in prisons. Even as young key population are recognized as a vulnerable group, the global response to HIV has largely sidelined young people. To address this, Kenya has developed the Fast Track Plan and the National Implementation Guidelines for HIV and STI programming among young key population. A pilot intervention was initiated with young men who have sex with men and young women who sell sex in Kiambu and Mombasa respectively. We partnered with MPEG, a KP-led organization in Kiambu, and ICRH Kenya, an NGO which works in Mombasa.
Kwa majina naitwa Margaret Wamboka, nimetoka mtaa Bombolulu. Napenda sherehe, napenda sheshe, kutoka nje na mabeshte, kuchonga, kukunywa. Yaani hivyo ndio mimi tu anapenda. Kuna siku ilikuwa naenda tu kibarua tu hivi kama kawaida, nikakutana na Pia. Sasa huyo Pia akanielezea, akaniita, mambo poa dada, kuna services tunafanya pale DIC. Kama unataka family planning, alafu nikikumbuka ndio nimetoka kuzaa, alafu sijui mambo na family planning, akanielezea kuna miezi 3, kuna miaka 5, kuna zile pills. Alivyonielezea, alafu akaniambia kuna tembe zinaitwa PrEP. Alivyoniambia hivyo, nikafikiria, nikamfuata paka huko DIC. Nilipofika nikapatiwa service, nikaelezea, nikapatiwa cancel.
Young key populations not only experience higher risk of acquiring HIV, but are also vulnerable due to a myriad of social and structural factors. For example, while unprotected sex is a significant risk factor, there is evidence that young key population are often more vulnerable to effects of poverty, discrimination, harassment, violence, social isolation, criminalization, and self-stigmatization. In addition to addressing multiple overlapping risks, programs with young key population are working towards developing supportive policies, providing stigma-free services, improving access to scholarship for education and skills training, violence-related support, among many others.
Nilivyomaliza hizo service, sasa nikakuja na mimi pia nikaelezea wenzangu. Pia wenzangu nikiwapeleka wanatumia hizo prep, hizo service za family planning. Sasa pia huko kwa hotspots kwa sababu pia mimi nabangaiza. Sasa zile service zilinisaidia DC, nikaambia na wenzangu sex worker wadogo, nikawaelezea kuhusu hizo service na wapeleka pia nao wanaambia wengine wanaenda.
There are a host of reasons why young people, particularly adolescents and young girls, sell sex. Poverty, gender inequality, and limited access to education are just the tip of the iceberg. Yet even while transitions research from Mombasa indicates that 52% of women who sell sex in sex work locations are below 24 years, they remain underrepresented in research and HIV prevention programs.
I came to know MPEG at around 2017 after high school. You know, this was the time when I was so naive. I didn't know things about how I can prevent myself from HIV or from STIs or where I can get services. So I came across a friend who was actually working in this DIC, and he introduced me here. At first I was hesitant because I thought maybe, I don't know these people, what are they going to do to me? But after some time, when I got here, the reception was very welcoming. So I registered my name, went to the doctor, had a conversation with the doctor, and I got enrolled.
So there was need to bring those hard to reach people, youngsters that are online, are all over online, and they don't want to come to seek services. Youngsters want to be reached by youngsters. I want mtu tunaongea na yeye ana resonate na mimi, tuko almost the same age. Alafu si kukwambia tu, don't just tell me about coming for HIV. You see, that is what have led a lot of sites not even have young people, because our sites have become like hospitals. There is nowhere you'll find youngsters chilling together, playing PS, watching a movie together, doing makeup. You see, having a movie night, kukula popcorns pamoja. There is not that, because our sites have become hospitals. Unasikia tu madawa, unasikia tu watu wagonjwa. So there was that gap to change, to make it more friendly, to attract more people, more youth to come to the center. And you will find them. You will not find them in the streets. You'll find them on social media. We have social sites, we have groups, and all those social network and sexual networks. Those are two places that you'll find a lot of youth.
The way they welcomed me to the doctor, I was already comfortable with their services, and once I got to the doctor, he introduced me to the organization. He told me what they do. They offer HIV prevention services, they give STI services. In case you have any diseases, you can come here and get any service for free. This was something that was really exciting, because I was used to going to like public hospitals, and when you go usually to public hospitals, most of the time they won't make you feel home. So the kind of reception that was here made me feel good, and I think we had a connection, and I came and started receiving services from the DICE.
Data on young men who have sex with men is scarce. However, emerging numbers point to them having heightened risk and vulnerability. There are a few programs specifically tailored to their needs, which limit their access to sexual health education and services. They also face criminalization and the stigma attached to same-sex relationships. As a group, they are at increased risk of abandonment and violence from their families.
We normally offer services to the young KP, that is the biomedical intervention, structural and behavioral. We also do the psychological support to them, because most of them are actually going a lot of mental health challenges. And most of them, they find these places a bit safe for them to come and share with us. So we do offer the services to them still.
The country has developed guidelines to inform national programming for HIV and STIs among young key populations. The guidelines emphasize the need to involve the young key population at all levels of program and policy design, implementation, and evaluation so they can own the program.
Yeah. Mimi hadi nikiwa tawa, I can just peep in, kukaa kiasi, relax, wifi deals ni kwa manga. Hiyo pia inasaidia. Uko na place penye hautaenda ukae ulizwe nini unakuja kufanya hapa. Yeah.
Una feel at home, you can do anything you want. Like no one is there, no one is judging you. Unakuja kani lunch time, maybe you're working, na kama una chill. Kama leo. Venye tulikam, unapata kuna wase wengine kwa share. Sisi tukam unapata mabest, you can make friends.
Watu wa form wanakuja kupikia form. It's just fun hanging out with friends and for your well-being.
Children and adolescents below the age of 18 are exceedingly vulnerable to sexual exploitation. They have a greater inability to negotiate safe sex, access sexual and reproductive health services, and exist under the constant fear of harassment and exploitation. This drives them away from programs and services, making them invincible. Yet young KPs are protected under several laws, including the United Nations Convention on the Rights of the Child, UNCRC, the African Charter of the Rights of the Child, ACRWC, the Constitution of Kenya, and the Children's Act of 2001. These provide for the survival, development, protection, and participation rights of YKPs.
The challenges we face in programming for young KP are many, and some of the issues we find is during our outreaches and being in places where sex work is happening, we find young girls and boys under 18 who are selling sex. Since they're already in those areas, we provide services for them. And so we'll give them services like sexually transmitted infection screening for them, HIV testing for them, provide treatment. But before that, the most important is linking them to child services.
Young key population need to be effectively included in the HIV response. To do this, an understanding and recognition of the emerging needs of this group is required.
The policy guidelines have in various ways contributed to addressing the needs of YKP. The first thing is that the policy guidelines give practitioners and programs some level of confidence to approach KP or YKP service delivery. So one of the things you find or you know is that it's quite controversial providing sexual reproductive health services to young people, and many clinicians are often reluctant to provide sexual reproductive health services to young people. But one of the things the guidelines have done is that they now health service providers and programs are aware that there are policies and that there are guidelines and that they are operating within a legal framework, and that gives them a lot more confidence to provide services to most or to many of these people.
For the government of Kenya and the counties, it has been that challenge of ensuring we meet the prevention need as we work towards abiding by law and working towards behavior change. And so to facilitate this, we set up county key populations TWGs, whose role, apart from the general key population, has been to address emerging concerns and trends around key population program and prevention needs. And so this has become a concern in all KP TWGs, and that has given a platform for engagement with the stakeholders who have a responsibility over young people who are KP in their lifestyles, bringing together education, security, judiciary, and that has given the structural environment for provision of prevention services.
While programming for young key populations is still in the early stages, it is essential to anchor the provision of services to select key principles. These include ensuring that young key populations have their voices heard, minimizing harm to them, not discriminating on any grounds, and remaining aware of their vulnerability. To achieve maximum benefit, collaboration with families, community leaders, county bodies, and different sectors will be essential. Young key populations have needs beyond HIV and health, and hence the program would have to ensure that all these needs are met in partnership with other organizations.
There was really a gap to really reach out to the young KP because they have needs that cannot be reached in the mature program, because these are young people, and for young people they need a lot of sexual and reproductive health services. They need a lot of integration of youth services and youth-friendly services. For the general KP, it's just ensuring that, of course, you reach them with specific services, but services that are KP-friendly. But for this one, apart from KP-friendly, it also has to be youth-friendly.
We need to create an environment whereby young key populations can actually share. That is ensuring that there is safe spaces, be it at drop-in centers, be it just, at homes, because young key populations are part and parcel of the community. And since they are our leaders of tomorrow, we need to ensure that they are equipped with education. And this only happens at safer spaces.
Sasa mimi nina miaka 22 na niliingia DIC nikiwa na miaka 17. Nashukuru imenisaidia kwa sababu ilikuwa sijui mambo na family planning, wakanisaidia. Hasa nashukuru DIC kwa kunielimisha.
If you'd like to learn more about Kenya's programming for young key population, send an email to NASCOP through their website www.nascop.or.ke.
Thank you so much, Mary, for this great presentation and movie. Are there any additions you'd like to make?
Hi, Clement. For now, not really. Maybe learning from what we have begun. I'm sure there's a lot of improvement that we need to do. I have seen some comments on age of consent. I think I have replied for Kenya, but we will work through lowering that age of consent so that young key populations are able to access services more. Thank you.
Great. Thank you so much, Mary, for this great presentation and movie you shared with us. The next session will actually look at Nothing for Us Without Us, involving young key populations. And we'll have two presenters here, Rita Gatonye from Kenya and Lingford Soko from Zambia, sharing their perspectives on work with young key populations. So over to you, Rita, for your presentation.
Just trying to turn my video on. Is it? Okay, good.
We can see you now and can hear you.
Okay, thank you. So hi everybody. Thank you so much for making my work so much easier with the presentations. I must admit that I'm coming into this with a bit of an advantage because I am from Kenya and we have just had a presentation from Kenya. So I don't want to, to repeat too many points, but I might just give a short story just to start us off with this. So I want to give you a very short story about a friend of mine. Let's call her Mary. So Mary and I were in high school together, and we started experimenting with marijuana and with cocaine in high school together. And however, we lost track of each other. And at the age of when Mary was 16, she started to sell sex because of being unable to raise school fees for school. So So as she was doing this, in the process of selling sex and injecting drugs, she contracted HIV, and then we lost track of each other again because she went into isolation. Mary, since that time, has been engaged with different key population organizations, has been a peer educator, has been an outreach worker, that is for the past more than 10 years. And Mary at this point is still in problematic drug use, does not quite adhere to services, doesn't have the hobbies that she used to have because she was a poet, and is still deep in the throes of self-stigma. And as much as we try, Mary is not coming for services. Mary is 30 years old now, but she's not coming. I have another friend, let's call her Tunda. Tunda started using drugs. Tunda is currently now 21. She started using heroin about 5 years ago. Tunda is a peer educator at one of the drop-in centers, and Tunda is also living with HIV. However, she adheres to her medication. She has one child, and she's currently on family planning services, and she's very engaged with young key populations in her own space and organizations that work for young key populations. So that with that background, I think what I'm trying to point out is the need, the differences that come with young key population leadership and the kind of engagement that people have and the kind of issues that young key populations face. And the fact that if interventions are not given early enough, then by the time young key populations are older, then it becomes difficult to intervene. So I don't want to go into the challenges too much, but I will say that as everybody has said, to be young is to be curious, is to be searching for identity, is to be experimenting, is to be naive, is to be inexperienced and underexposed, is to be social, and is to be seeking acceptance. Being young in this jurisdiction is also being left out, is also being silenced, is also being controlled, and being dependent completely on the rest of the society for information and resources. The challenges, as have been mentioned, apart from the obvious ones of criminalization of say, drug use and sex work and same-sex relations, is the criminalization of knowledge, generally in the court of public opinion. Outside of the policies even, it's the criminalization of knowledge that falls outside the accepted purview for young people. It's also the underrepresentation, as has been said, not just in research and services, but in advocacy efforts. And I would say that this is because of issues of capacity, low literacy levels for young people, underexposure and underexperience. So issues of capacity, competence, and then of course the issues of assent and consent for sex and for services. Underrepresentation is also as a result of donors' insistence on working with a specific, or not working with some donors, straight up will not work with young key populations for obvious reasons. And then even where there is policies that allow for assent for young key populations, for example, in my context, I don't think that young women who use drugs in Kenya are aware that that under the age of 18, they can actually still access services. Social stigmatization of behavior, of course, is more for young people than for older, more seasoned people. And then there's a lack of access to non-stigmatizing information. So even where there is information about sexual and reproductive health and information about drug use, it's stigmatizing, it's fear-mongering, it's, if you do this, this will happen. It's not very, very friendly. And we know young people respond better to information that's given to them in a friendly manner. We also have a bit of an issue with commodities for sexual and reproductive health. I'm speaking specifically for young women who use drugs, often complain that even where there is information, commodities are an issue, either expensive at the general centers or unavailable at the KP centers that we are used to going to. Of course, there is reduced negotiating power, as was said, both for sex work, and for drug use, and also for dealing with police, for access to justice. There's just reduced negotiating power. And then for young people who use drugs specifically, by the time we can engage in design and planning and implementation of services, we are usually older. So we begin like my friend Tunda and Mary did. By the time they could be engaged, this was much later. And this is because the drug use and the sex work had become problematic and had kept them away for a very long time. So the need to intervene early cannot be understated. So, and we have new drug users using drugs problematically, and new young people going into sex work every day, especially with the socioeconomic conditions getting more difficult. As for best practices that I personally have seen is, number one, young people need not to have their youth seen as a disability, not to have their youngness, so to speak, condemned. Young people aren't supposed to be left to their own devices in terms of looking for information, looking for the right information. I feel like this information should be offered freely, readily, and in a language that they understand. Young people, as has been said in the lovely video, young people love to learn from other young people. It's very encouraging to see somebody of your age teaching you something, and it tends to stick better. Young people also need to see themselves represented in positions of leadership. Representation is very important. And this leadership is in a language and a style that is understandable to them themselves. For example, programs that have the digital spaces and the artistic spaces and that explore different modes of learning. This allows young people to have a sense of ownership of their programs. There needs to be an allowance for innovation in the donor space. So some donors in the past would not fund some kinds of programs. Even digital work up until a few years ago was difficult to pitch to some donors until the COVID pandemic came and forced us all to rethink how we were reaching people. We also need, and when I say we, I'm putting myself in the young people box. We also need flexible allowances for what can be done. For example, as has been said, socioeconomic empowerment is key. It cannot be left out when talking about young people, especially because of the aspect of poverty and the lack of skills that lead to all the issues that we now see. Some good examples are, for example, what has been shown by MPEG and by NASCOP in creating safe spaces for young people at our organization as well, which is known as Women in Response to HIV/AIDS and Drug Addiction. We have peer counselors of the same age, as well as having a buddy system. So we have the older generation, more seasoned generation, acting as sort of like big brothers, big sisters. And when that, and to fill the gap that's brought by that, we have peer counselors of the exact same age set as that. I also know that Input Input is also mobilizing young people who use drugs in Kenya, Uganda, and Tanzania. We are also working on that with Input. So that is deliberate affirmative action for and by young people. Youth Rise is also really keen on developing the capacities of young people. And just to add to a few more recommendations of the minimum package, I would say SRHR, commodities and information, and capacity building, to build that competence and capacity so that even somebody who is 16 years old may not have reached the age of consent, may not understand, but may understand assent because they have had their capacity built. I believe family and social reintegration can play a big role, although, in different contexts because it's tricky. But getting to that reintegration bit early before the inherited biases of the larger community can fully set in would be a good intervention to ensure that young key populations are protected from the onset. We need to fill in the information gap that's been left by the national policies that don't favor access to information. For example, our SRH situation in East Africa. So that needs to be a deliberate effort. I also will vouch for community-led and participatory research, because as was said, young people are the ones who know how to speak to their peers, where they will get them, and how to get them to bring out their issues. Donors also need to sit with nations and communities to find ways around the consent gap so that young people can be reached by services. And as I said earlier, affirmative action, some sort of affirmative action for young key populations in terms of ensuring that we work with young KP leadership, and even where there is where it's adult KP leadership, we have, for example, a certain number of slots for certain activities should be set aside for young people. And with that, I would just like to reiterate that this is a very important conversation. I'm really looking forward to hearing more from especially the Kenyan team on the Scalar Plans. I'm really looking forward to see how that can be done and to work together in doing that. Yeah. So I hope I've stayed within the time limit. A lot of the wonderful things have already been said. Mine is just to reiterate that nothing for us without us, and nothing for us unless by us. So thank you.
Thank you so much, Rita. And Rita she introduced herself in the chat with Women in Response to HIV/AIDS and Drug Use in East Africa. And with that, I'll hand over straight to Lingford Soko from Zambia, who I believe will share slides as well. So over to you, Lingford. Lingford, we see your slides. We cannot hear you yet.
Sorry, it was the mic was mute. Sorry. Can you hear me now?
We can hear you now, and we cannot see you. If you'd like to switch on your camera, that would be fine, but otherwise you could also just proceed. Can see you now, Lingford. Over to you.
Thank you so much, sir. I'm sorry, where I'm seated, there's some bit of noise. Hope you can get me clearly. My name is Lingford Soko from Zambia. An ex-juvenile. I was in prison from the year 2015 to 2017. Can someone confirm if I'm audible enough?
You're audible and we can see your slide, so please feel free to continue.
All right, thank you so much. Yeah, so as you can read from the presentation, I'll be actually just going through the very same points that I raised in this presentation. In Zambia, we currently have over 23,400 inmates locked in facilities that were meant to cater for less than a quarter of that number.
We cannot hear you now, Lingford. I don't know if you went on mute.
Due to the fact that most of the prisons in Zambia were constructed time immemorial. Like we only have, if not 2 or 3 prisons that are in modern state. The rest, or 99.9%, were constructed in time immemorial. By then, corporal punishment was the ultimate goal for the then prison service, which is currently the Zambian Correction Center. And in these facilities or in these prisons, that I've been through. I witnessed the situation. The food that is given to the inmates is not nutritious, such that people with HIV, people with tuberculosis, and the young ones are really in danger, and their medical condition get worsened once they are in prison facilities. Poor medical services and shortages of drug is unspeakable in these correctional facilities and poses a threat to HIV and AIDS patients. As it was evidenced in the Supreme Court case, there was a case in Zambia where two prisoners had sought petition seeking for the court's intervention, looking into the fact that they were on medical prescription, like they were HIV positive, and they took the prison service to court so that they can have at least the prescribed food and the antiretroviral drugs, ARVs, given to them. In this matter, when they went to the High Court, the petition was dismissed, claiming that the prison service did not violate any of their rights by not giving them enough food and the medicine which they were supposed to be accessing as they were locked up in the prison service. But they appealed to the Supreme Court, and the decision was overturned by the Supreme Court judge, by then Judge Mumba Malila, which he claimed to say, you cannot have the right to life if you are not subjected to the right food, or if you're not giving the right food and the drugs that you're supposed to access. And looking into the fact that those people were matured enough, were adults, unlike the Yankee population, like was my case by then, I never knew any rights, which is the case. Most juveniles in prisons, they don't know their rights, they don't know what they deserve, they don't know what they're supposed to be getting or what they are supposed to be treated like, which is indeed a great danger in the prison facilities. The overcrowding of inmates in cells poses a great danger to you and the young ones, like was my case, for there is no room for separation of the sick and the juveniles in prison service. What it is in prison is that you find that, for example, here in Lusaka, the prison cells that were supposed to be meant for let me share the screen with you. Yeah, there's this picture here. I don't know if you can see it. This is the sleeping condition in prisons, which is of great danger to those people that are, for example, sick of tuberculosis, which is a airborne disease or airly transmitted disease, and also for those HIV and AIDS patients and the young ones. As you can see there, you find that there is no breathing space. There is no space where you can take juveniles. And this is the situation in almost each and every cell. So you find that the young ones are mixed with the elderly and the sick, which is indeed not a situation that one would like to experience. As when it comes to sanitation, prison service sanitation is something that one wouldn't want to speak of. Another thing that is of great danger, which I went through as I was in prison, is the fact that elderly inmates and the young ones are not separated from the, or to be put into their specific cells where they can have the interaction with their fellow young ones, they end up learning bad behavior or the real criminal knowledge from the elderly inmates.
Lingford, your line is probably breaking, and you have maybe,
As it
2 minutes
was in my case, you find that you go to prison with a petty offense, mixing with the orderly inmates, you other incentives. Or I'm sorry, the network might be bad, but my presentation has almost all the details that I wanted to convey to this meeting.
Yes, please
the
go
network
ahead.
is bad. Thank you. Yeah, the social in young key populations in prison end up learning bad behavior by way of being mixed with the orderly inmates, which is indeed something that we have to work on as we are trying to prevent crimes, as we are trying to reduce the rate of HIV and AIDS, as well as we are trying to stop young key populations from indulging into bad behavior. There is also need to make sure that as we are taken to prison, or as young ones are going to prison, they are being given the conditions or the mental health that they can at least reform instead of going to prison and becoming more dangerous to the society. I think with the few remarks, I would like to thank you for the opportunity. I've been told that I have limited time, or actually 2 or 1 minute. So I thank you.
Thank you so much, Lingford, for this great perspective, which really enriches this discussion and brings a lived reality from a prison setting, which we often don't talk about enough in this context. So we are really grateful for the perspective that you shared, and despite the slight connection issues that we've had and which delayed us a bit, I think we've gotten your key message, and would be great to have your slides for dissemination. We now move to the next step, and which is a panel discussion to actually hear perspectives again from government, funding partners, and the community on what we have heard, what we have discussed, and what we can actually take forward in this work. So without further ado, I'll maybe ask Humphrey Ndondo from Zimbabwe first on the perspective from NAC in Zimbabwe. Masikati Ndondo, and over to you. What more needs to be done actually to scale up programs for young key populations? Could be one question to focus on.
Good afternoon, Clemens, and good afternoon, colleagues. I think from our perspective, we have had 4 decades of responding to HIV, and there's quite a lot that we have learned in terms of responding to communities that are living on the margins. In the past 4 decades, we have been talking about, the consequences of leaving communities behind, and we have these fancy and catchy slogans around know your epidemic, know your response. Our epidemics are telling us that younger persons are disproportionately affected by HIV and other SRHR issues. We have been talking about leaving no one and ending AIDS by 2030. And for this to be a reality in the 8 years that are coming, we need to be accelerating the way that we have been responding, or we have been changing the way that we have been responding to the HIV epidemic as it affects younger persons. I think we need to be very deliberate and purposeful about engagement, meaningful engagement of younger persons. They are here today telling us that we are not going to be successful if we are doing anything without them. So really be purposeful and deliberate about inclusion of young people, because they are marginalized constituency, and evidence points to this disproportionate burden of disease. And we have seen that further to being young, once sexual orientation and gender identity and sexual characteristics and traits further marginalize individuals. Young persons who are selling sex are also disproportionately affected. Young persons in conflict situations, we hardly ever talk about them. But we know that in areas where there's conflict, there's also a greater or disproportionate burden of disease amongst younger people. We are seeing the play of complex legislative environments, and particularly how they affect younger persons. And this can be based or really rooted around our religion, our cultures, patriarchy. They can also be rooted in our legislation. And these actually prohibit the access to affirming, autonomous adolescent HIV/SRA services. And we need to draw the lines between crime and the celebration of diversity, a celebration of autonomy, and a respect for people's independence and choice. And I think we are not so used to these words where communities should have agency for their voices. They should be making choices. I think we should get to learn this language more. We have also need to invest in research. We are inadequately investing in research, particularly to young people in sub-Saharan Africa. We want to understand and unpack more of what are the barriers to access to services, and maybe lastly, to really rethink and discharge some of the ways around how we are moralizing and gatekeeping the HIV response, as parents, as programmers, as guardians, as educators, and as legislators. We have policies that, are actually policing sexual expression, that actually policies sexuality education, that reinforces a culture of silence, that reinforces that when we are uncomfortable about talking about anal sex, about sex work, etc., we want to keep quiet about those things. So I think we are calling for a new way of thinking and a new way of practice within the HIV response, where we are not afraid as governments to be unpopular or to have programs that are really robust and particularly speak to the epidemic that we have in our countries rather than the epidemic that we want to respond to. I will stop there because I realize we don't have time for the other panelists. Over.
Right, Ambassador. Thank you, Humphrey. And with that, I'll pass straight to the next panelist, Tisha Wheeler from USAID. And with the question, what more needs to be done to include and scale up programs to reach young key populations, given that we have guidance, we have examples, good practice examples, but we still see those glaring gaps when it comes to the scale of programs, their reach, and their engagement with young key populations. Over to you, Tisha.
Thank you, Clemens. My name is Tisha Wheeler, and I am the Key Populations and Rights Branch Chief at USAID, and I'm here on behalf of the Key Populations Community of Practice in PEPFAR. I wanted to respond to this question by saying, I think, first of all, donors and governments, we're kind of in the same position where we have a lot of HIV/AIDS funding, which goes through different implementing partners to do different things. And the challenge really is listening to the voices like those we've heard on the call today to understand where the problems lie, where the challenges are, who's falling out of services or who's not reaching the services that they need. And I think young key populations are among the most vulnerable of the vulnerable. When a young person goes into an environment where sexual activity is heightened and the risk is heightened, and the protections that are there, maybe even among a social network of sex workers don't exist for a young key population, the likelihood of seroconversion is much greater. We must reach these young people. So that is our challenge. But we have these infrastructures of the different partners we fund for the different things. And so how do we scale? How do we reach these people with the services that they need? We started out by completely revising the COP22 guidance, the guidance that went out with our last annual planning cycle in PEPFAR, to include young people who are key populations in a much more nuanced way. So we have guidance, which you could read online. And I think that it points to a few things, which I wanted to highlight today. One is that key populations, addressing them through PEPFAR is something that's been done, especially through implementing partners who care and who see young key populations. But for us to scale that is something completely new. We understand that the needs of young key populations can be very specific. And while we find young key populations, for example, in PEPFAR through our DREAMS programs or through our KP programs, neither program is sufficient to meet these specific needs. So you need to tailor programming to them and to the context. And in doing so, you need to make sure that the services are differentiated, right? So among the things that we can kind of say are standardized are an integrated package of services. And that includes comprehensive HIV program and sexual and reproductive health, voluntary family planning, integrated structural interventions to enhance the agency of the individual, help them understand, their rights, as the speaker from Zambia was saying, help them understand, the nature of violence, and that it's, that there could be resources to help them if they face violence, and providing psychosocial support. Typically, we need peer educators to be younger or to understand how to speak with young people, how to connect with young people through social media for follow-up, so that it can be immediate and it can be accessible to that young person, not just when they might be in a physical location. And then ensuring a linkage to social protections and socioeconomic empowerment services. And for all referrals that we provide, we have to do follow-up. You can't just simply tell somebody about a service, but you have to assist them and you have to follow up and make sure they have that service. So there's a lot to say about what we're learning, and there's a lot that can be done for scaling, but I think understanding how the different partners who we fund are linking together and problem solving and helping to refer individuals who are seen in different services and link them together is essential. And then, there's a little extra funding that's needed for young key populations over and above what would be a scaled already service, to allow for this kind of flexibility. So it's certainly an emerging issue in PEPFAR that we want to address. We want to learn from those of you who are on this call. And for governments who are on this call, we are ready to have the conversation. We're ready to scale up with you. So thank you very much for the opportunity, Clemens. And please reach out to me or my CDC colleagues in country, USAID colleagues in country, to help us, improve the efforts for young key populations. Thank you.
Thank you so much, Tisha, for this great perspective from programmatic and financing angles. Same question to Ed Ngoksin from the Global Fund.
Great, Clemens, and thank you so much for inviting me to share my reflections. And my message is really similar to Tisha. As the funders, I think there's a lot more to do. My name is Ed Ngoksin, and I coordinate the work on key population at the Global Fund. And first of all, I think it's important to also acknowledge that we are so far behind in terms of providing funding for programs for key population more generally. And we have a huge service gaps amongst adult key populations, let alone the young KPs. So your question, Clemens, about what can be done? Obviously, I think we need a better ways of prioritizing funding and put the money where the mouth is, where the new infection is rising, and also address inequity and access to services. And the young key populations obviously are in the center of this question. So as the Global Fund prepare for the next funding cycle, we are trying to find way to be much more strategic in supporting countries to do so, and also hold countries accountable for their commitments for co-financing of programs, as well as supporting countries working with partners to help them better measure prevention outcomes in their programs. So in my view, what is really important is to make sure that key population programs and youth program work hand in hand to provide age-appropriate services and create multiple entry points for HIV services, taking into account the overlapping vulnerabilities that Boyan talked about earlier. And that includes looking at the harms associated with sexualized drug use, mental health, down to homelessness, sex work, poverty, and so on and so forth, while most critically important principle is to do no harm, especially when it comes to engaging, delivering services to and reporting on adolescents' key populations. In addition, what we really want countries to do better is to, and when it is safe and practical to do so, to start collecting, analyzing, and using age and sex disaggregated data across the service cascade to inform program. And we are very clear in our guidance that we want to privilege peer-based services, that they are better prioritized along with the digital platform for delivery, creating the safe spaces that many of the speakers speak today. So these are very explicit in our current guidance, and we make sure that we continue to highlight it in the new funding cycle. And finally, improving sexual reproductive health, sexual health and well-being, making sure HIV services are available in multiple platforms so that young people in all diversities, including young key populations, have access to options. And this is what Humphrey really eloquently put it, choices for young people in terms of HIV prevention that works for them. So we're committed to scaling up PrEP, the period ring, and other prevention methods that really speak to young people. Our strategy is really clear about it, and we would take the lessons learned from how we partner with countries to scale up programs for young key populations. And you heard from Mary from NASCOP early on. And finally, again, the most important point in the scaling up of young key population programs is to ensure meaningful engagement in decision-making. This is a non-negotiable principle, as well as scaling up comprehensive program to address human rights and gender-related barriers, including criminalizations. And this is key to success, is to provide funding and technical support for youth-led and key population-led organizations. So thank you so much for all the speakers and for sharing their brilliant insight and lessons learned. Back to you, Clement.
Thank you so much, Ed. Yeah, great perspective from the Global Fund, illustrating one more time there's clear commitment globally to support country efforts in strengthening programs for young key populations specifically. Aditya Taslim from Input has the last word, and without further ado and in the interest of time, I'll hand straight to you, Aditya.
Thanks, Clemens, and thank you everyone for all the speakers, and also hi to everyone listening. I'm Aditya. I'm with the International Network of People Who Use Drugs, but I am based in Indonesia. So good evening from here. Just picking up a few important points from the discussion today. Particularly one thing that I was so interested, but we didn't really get a chance to unpack a bit more was, I think Boyan mentioned that in the presentation, on the design of programs for young key population, not just only for young key population, but I think for key population in general. Rita also touched on this briefly on, you know, it's really important to have services and responses are done in a friendly manner, that are friendly to young key population and also to key population. And despite that, I mean, key population programs, including services responses, are are mentioned a lot in many countries, but then often we don't see many of these responses and services. They don't really address the needs and also the values and preferences of key population. Now, take an example of this. If you're a drug user and if you come to service to access needle and syringes or opioid agonist treatment, then you might get the service, but then while accessing the service, then health service providers will lecture you on, oh yeah, you're still young, why are you using drugs? No, drugs is really not good for your health. And you know, those values and preferences, they're often not, they're often forgotten and neglected. And sadly, in many cases, the availability of services is really just and can be seen as the only indicator. Oh yeah, we have harm reduction service, we have services on SRHR, but then we don't really dig deeper into how are we actually delivering the services, particularly for key population and young key population. And that this can be very, very critical, because then this stigmatization and discrimination and can really hit hard on us, on key populations and young key populations, and especially in countries where we're still criminalized. And we shall not forget that 39 countries still criminalize same-sex, 150 still criminalize sex work, 169 still criminalize drug use and possession, 111 countries still impose age restrictions to access services. And if we are to achieve the 10-10-10 targets, then it's 2025 targets. So it's what, 3.5 years from now. So there's a lot of work that we need to focus on. And when we see, I mean, yes, we see stronger human rights and key population enabling environments, programs related to those areas, but we don't often see that this comes with investment to key population-led organizations. And we need that dedicated funding stream for key population-led organizations, networks, smaller groups, or even non-formally registered key population-led groups. And also remember that in some countries that it's quite impossible for key populations or young key population to form an organization formally, thus it might not be recognized by most of donors. And so, yeah, I guess that's, I mean, it's really something that we need to consider. Structural barriers are really an issue that we need to focus on. And also we need to ask ourselves whether, you know, since the adoption of the Global AIDS Strategy and the political declaration commitments, like how many countries do we see these new targets reflected in their national strategic plan? How many countries do we see the 10-10-10 targets on the national targets? Are they being discussed in national dialogues? Do we see key population seating in those dialogues? And do we invest in key population-led organization? So thank you so much for having me here. And yes, thank you.
Thank you so much, Aditya, for this round and overall perspective on the key population and young key population response from a community perspective. We've gone over time, so I will not attempt to summarize and synthesize everything again, just to say that we have had clear directions from this call from the communities, from the implementers, that it's very much about engagement and preferences of young key populations. Nothing for us without us involving choice and addressing those specific barriers that we can understand by listening to young key populations. At the same time, there's a programmatic dimension here, which requires, and we've heard that both from Global Fund and US government, requires extra funding, and there is interest to actually invest in this area, requires differentiated packages, integrated program and services, including some SRH and violence dimensions. The outreach that is specific to the young people, so involves younger people as well. Media-based interventions coming out as young people use specific types of new media, and all of that together with existing funding and using the examples that we've seen also from Kenya today could really provide strengthening to the existing response and the platforms that are out there. And I guess there's a real practical way forward in doing this. And with this, I think we have a large work program to do, and different fora, including the South Learning Network, and we'll take this forward and unpack it in a lot of more detailed work. And obviously all the materials will be made available to you and can also guide you in advancing this work. And we remain available both as the UN system, as partners in the Global Prevention Coalition, involving all the agencies that have been present today, and also South Learning Network would be happy to work with you in taking this forward. And last but not least, all the sessions, including this session, will be available in the YouTube channel actually that we have for the South Learning Network and the Community of Practice sessions. So if you want to also see the great presentations we had this morning, including from some other regions, the Philippines, for example, and you will be able to access that through us or through the Learning Network webpage. So thank you, everybody, and looking forward to future engagements.